Ladies and gentlemen, it's a pleasure to be here to discuss the clinical interpretation of discordant thyroid function tests. Well, we know that hypothyroidism is a common disease, and this is my paper which I published in 2013, which shows that about 3.5% of the population uh, could have hypothyroidism in India, and the prevalence of subclinical hypothyroidism could be as high as 8%. But we know that in some populations, such as women, this may be more. This is also a study we published, which looked at the prevalence of thyroid dysfunction among young women, and we found that a significant proportion of young women, almost 9.7%, had a TSH that was between 4.5 to 10, and uh, a smaller percentage of 1.3 had a TSH uh, of above 10. With that background, let me discuss a few cases which will uh, through which I will try to explain how to interpret some of these discordant thyroid function tests. I call the first case as the TSH just won't come down. This is a 40-year-old lady who came with non-specific body aches and there was no goiter. All the clinical features and examinations and investigations were normal. Her anti-TPO antibody results were also negative. Well, if you see her thyroid functions, you can see that her T3 is normal, her T4 is also normal, but the TSH is 6.3. So that shows that the TSH is above normal. Now, this is what happened to her after 3 months of thyroxine 50 micrograms. You will see that her T3, T4, and TSH have remained identical. In fact, you can see that the T4 has gone up on thyroxine, the T3 has not increased much, and the TSH has remained static. Well, there are several factors to consider here, and one of the most important factor is patient compliance, the particular medication, and third is whether the patient is breaking the tablet into two, which can lead to losses. So in this patient, the reason was, of course, patient compliance, but I will look at uh, this case in a different way. Supposing the TSH hadn't come down, should you consider, if you've ruled out compliance, if you ruled out other causes, should you consider some other possibility? So whenever you see a patient whom you've treated with thyroxine and the TSH hasn't come down and you've ruled out compliance, breaking the tablet, etc., then you should think of some other reasons. So we know that the TSH is measured by using a dual antibody sandwich technique. So you have the TSH, which is an antigen. You have a solid phase antibody, binds to the surface. So it is sort of connecting the antigen to the surface. And the second antibody is a soluble labeled antibody, which is a signal antibody. So whenever the antigen is bound between the solid antibody and the signal antibody, only then the immunoassay actually shows up the antigen. But if there is some of the people with thyroid diseases have interfering antibodies. So you can see this pink colored interfering antibody, which has now bound to both the solid phase antibody and the soluble antibody. And there's no TSH there, but the immunoassay is now picking up this antibody as a, an antigen. So the immunoassay will show this as TSH, but it's just an antibody. So the question is that supposing a patient's TSH doesn't come down, you'll have to look at the possibility of these antibodies. Some of these antibodies are called heterophile antibodies. And can this antibody be blocked? So yes, this interfering antibody can be blocked by using a simple mouse immunoglobulin. And if you use a mouse immunoglobulin, block these heterophile antibodies, then the true antigen, which is TSH, will bind to the soluble labeled antibody or the signal antibody and the solid phase antibody, also called the capture antibody. So in this particular paper published by Santanakrishnan et al., which was, this is not my paper, it is a published paper I used a case scenario to explain this. What they did is they increased the concentration of the mouse antibody to the assay. And when they did that, they found that the high TSH actually came down because the interfering antibody got neutralized. And what you are ending up measuring is the true TSH. So therefore, the message from my first case is that when you see a TSH that doesn't come down, always remember, patient may not be compliant. In fact, if the patient has not regularly taken the tablet and has just taken the tablet on the morning of the test, the T3, T4 will be normal, but the TSH will be high. And of course, there are other factors like breaking the tablet, etc., that may lead to this problem. But also, I discussed a very unique reason why the TSH does not come down, and that is heterophile antibodies, which bind to both signal and capture antibodies and interfere with TSH estimation, showing abnormally high TSH. These heterophile antibodies are sometimes even seen in Graves' disease, and you cannot treat Graves' disease, which is thyrotoxicosis, with thyroxine. Because it will become worse. So Graves' disease, you may get a slightly high TSH because of heterophile antibodies. Be careful to watch out for that. We don't have facilities to test these antibodies, heterophile antibodies, everywhere in India. So you will have to go by your clinical acumen. That I come to the next case, which is a very unique case I saw many years back. I call this case the mother and son do not agree in thyroid function test. This is a 26-year-old lady in her first pregnancy. She presented in the 7th month. She had classical features of thyrotoxicosis. The free T4 was high, 2.8. The TSH was low, and the TSH receptor antibodies were positive, suggesting that it is Graves' disease. Well, she was treated with anti-thyroid drugs, managed uneventfully. What are the indications for TSH receptor antibody testing? So there are several indications for TSH receptor antibody testing in thyrotoxicosis of pregnancy. Ideally, the testing is done at 22 weeks. If there is a past history of Graves or a suspected Graves disease, you need to do TSH receptor antibody. If there are very high TSH receptor antibody, you need to test it during pregnancy. And if there is a previous neonate in a mother with Graves disease, you need to check the TSH receptor antibody. So there is no need to do the TSH receptor antibody in every case. It's a costly test. Remember, you cannot do a radioiodine or a nuclear scintigraphy in pregnancy because it is contraindicated. So in pregnancy, when you suspect Graves' disease, please do a TSH receptor antibody. But in this lady, whom I treated with antithyroid drugs, had a normal pregnancy, normal delivery, but when the baby was born, I found something very puzzling. I found that the baby's TSH was high, 28, and the free T4 was low. Baby did not have a goiter, and the baby also had a TSH receptor antibody positive. So what we did is that I treated, because the T4 of the baby was low, the TSH was high. So obviously the baby had hypothyroidism. So I treated the baby with levothyroxine, but I could reduce the dose and stop it over the last 5 months. But the question here is what really happened? The mother had thyrotoxicosis, which was TSH receptor antibody positive, and the baby had hypothyroidism, which was also TSH receptor antibody positive. So what are the possibilities here? Well, you must remember that the TSH receptor has got an N terminal and a C terminal. Whenever the antibodies are directed against some of these epitopes, there is stimulation. So the TSH receptor antibody against, for example, the N terminal might result in stimulation of more thyroid hormone production, and it might signal thyrotoxicosis. But whenever the antibodies are produced against the C terminal, it suppresses. So the antibody against the C terminal will cause hypothyroidism. The normal TSH receptor antibody assay does not differentiate between a stimulating assay and a blocking assay. And it is also known that people with Graves' disease, their antibodies can switch from stimulating to blocking unpredictably. So there are some possibilities that could have happened in this mother who had thyrotoxicosis and the newborn who had hypothyroidism. One possibility could be that the TSH receptor antibody mediated neonatal hypothyroidism may have occurred because the mother may have had a transplacental TSH receptor blocking antibodies which have crossed to the placenta and the baby got hypothyroidism. Second is there is a chance effect. Hyperthyroidism is common, hypothyroidism is common. So the baby may have an unrelated congenital hypothyroidism. The third thing is antithyroid drugs given to the mother may cause the placenta, cause hypothyroidism in the baby. And the fourth possibility is that giving high dose of antithyroid hormones to the mother because maternal hypothyroidism in that, therefore less T4 may cross to the baby. So among these four possibilities, the likely possibility is the first one. Why? Because the mother was TSH receptor antibody positive, the baby was TSH receptor antibody positive. So the maternal TSH receptor antibodies crossed over to the baby. Now these antibodies stay in the blood only for about 3 to 5 months. So that's why I could reduce the thyroxine dose in the baby and stop it. And the mother's TSH receptor antibody, which was initially stimulating, the antibodies which went to baby at the time of birth were the blocking type. So the baby had hypothyroidism because of maternal TSH receptor blocking antibodies, and that hypothyroidism was transient or temporary because the antibodies disappeared after some time. So that's a likely explanation here. So I've come to my second case, which I called mother versus son, whose thyroid functions did not agree. So the reason for this was probably that the mother had TSH receptor stimulating antibodies, which later changed to TSH receptor blocking antibodies, which crossed over to the placenta and gave the baby hypothyroidism. Now, the third case, I call it Shraddhavan Labhate Jnanam, which means only the person who's really concentrating on the situation uh, may get a clue to what's going on. So, a case here, a 29-year-old lady, she presented with a slight goiter, again a case scenario, presents with a slight goiter and a pain in the throat. She's been on oral contraceptives for 1 year. The T4 is 16. Note, the T4 is high. The TSH is 0.5. Note, the TSH is low normal. So you have a high T4 and a low normal TSH. So I will discuss this case later. I'll allow you to think about this case. I'm sure many of you would have guessed the answer, but I'll just discuss this case, telling you what happened next. But after 2 months, when this lady was tested, the T4 was still high, 14. She was still on oral contraceptives, but the TSH went to 78. So what happened in this case? Local doctor, before referring, actually the GP got an MRI done because he said, oh, TSH is high, T4 is also high. So it could be a TSH producing pituitary tumor, but the MRI was normal. So what we did in this case is that we tested a free T4 and we found the free T4 to be 0.7 nanogram per deciliter, the normal 0.8 to 2.4. And therefore, this is a case of thyroiditis with transient toxicosis and eventual hypothyroidism. Overestimation of the T4 led the doctor to suspect TSH tumor. Let's go back to the slide. This lady had a slight goiter and a pain in the throat. That signals that there is painful thyroiditis going on. So the painful thyroiditis has actually suppressed the TSH. But why is the T4 high? Is it thyrotoxicosis? It may not be thyrotoxicosis. The high T4 is a high total T4. That high total T4 occurred because of oral contraceptives, which increase the thyroxine binding globulin, bind to T4 and increase the total T4. So in this case, the high total T4 is because of the lady being on oral contraceptives, and the low TSH was because of thyroiditis. What happened next? This thyroiditis resulted in toxicosis, and the T4 went up and TSH went down, but probably that was not detected. And in the next phase, at the end of 2 months, this lady went into hypothyroidism because thyroiditis with transient toxicosis is followed by hypothyroidism. And in hypothyroidism, the TSH has shot up to 78. The T4 is actually would be normal, but because of the oral contraceptives, the total T4 is still slightly high. And that's why when we did the free T4, we found that the free T4 was 0.7. So, ladies and gentlemen, thyroiditis with transient toxicosis and eventual hypothyroidism is a diagnosis. Why was the T4 high despite hypothyroidism? That was because of the oral contraceptives, which cause a high T4. You do a free T4, the problem can be solved. But in this case, an MRI probably not required. But the message is, whenever you have a patient on oral contraceptives and or pregnancy, always try to order the free T4 or multiply the total T4 by 1.5. The point I'm making is sometimes women may not tell us that they are on oral contraceptives, and you may like to ask them this question. So important to note that both T3 and T4 are predominantly bound to proteins called chaperone proteins. 97% of T3 is free. Is 97% of T3 is bound. Only 3% is free. 99.98% of T4 is bound. Only 0.02% is free. Whenever the thyroid function is altered, free T4 and total T4 will proceed concordantly. But when thyroxine binding globulin is also altered, in this situation, free T4 and total T4 will proceed discordantly, as in this patient. This happened. So, ladies and gentlemen, whenever you find high T3, high T4, and TSH, in this case, it was a recovery from thyroiditis with an oral contraceptive use. But you will look at other possibilities such as a TSH producing pituitary tumor or resistance to thyroid hormone. Well, one test that can pick up is a GS alpha subunit, and that GS alpha subunit of TSH is high in TSH producing pituitary tumors, but it may not be high when there is resistance to thyroid hormones. Point I'm trying to make is that resistance to thyroid hormones is very rare. TSH producing pituitary tumor is very rare. Having a patient with thyroiditis and on oral contraceptives is more likely. So, not a work, not needed that everybody should have a workup for MRI for TSH producing tumor or assessment for all these complicated tests for resistance to thyroid hormones. And that was my second point, Shraddhavan Labhate Jnanam, which means that focus uh, on the case, and small clues may give you gyan as to what's happening. For example, the slight goiter, slight pain in the neck, the history of oral contraceptive use, that could have helped pick up that this was simply a thyroiditis with high T4 due to oral contraceptive use, which is not always possible in a busy OPD. And that's why we are discussing these cases. That brings me to the fourth case, a man with many problems. This is a 40-year-old gentleman with a pneumonia, with liver disease, hypoventilation. He's got a soft goiter. He's admitted to ICU. He's been given inotropes and steroids. Now, he's got a T3 of 23 low, T4 of 5.4 low, the TSH is 30. So you get a consultation from the treating doctor as to, is this a non-thyroidal illness? Because all sorts of abnormal TFTs can be found in sick patients. Because this patient had liver disease, we did the free T4 and the free T4 was 0.2. So the free T4 was very low. And in this patient, the anti-TPO antibodies were also positive. So ladies and gentlemen, why am I showing this case? I'm showing this case to suggest that not all patients who are in the ICU have abnormal thyroid function tests, uh, have sick thyroid syndrome or non-thyroid illness. Some of them may have genuine hypothyroidism. For example, this patient with a TSH of 30. Yes, the TSH can go up in sick thyroid syndromes, but that is only after the critical illness has got better. During the critical illness, it's unlikely that the TSH will be high. And remember, this patient is on inotropes, dopamine, steroids. All of these can suppress the TSH. Despite that, the TSH in this patient is high. In addition, the patient has got a goiter. The free T4 is low, suggesting that the low total T4 is not because of liver disease. And of course, the anti-TPO antibody was positive. Remember, in liver disease, what happens is opposite to oral contraceptives. The thyroxine binding globulin is reduced, so the bound fraction is reduced, so the total T4 actually goes down. So therefore, I want to just add this point that any abnormal thyroid function can occur in non-thyroid. Always interpret that with a clinical judgment also. These changes of non-thyroid illness can be detected as soon as 2 hours after the onset of stress. And this change in thyroid function test is an energy saving, nitrogen sparing adaptation. So this slide shows all the different uh, patterns of non-thyroid illness. You can see the reverse T3 is usually high. You will see that the TSH is usually comes down, the total T4 comes down, the total T3 comes down. Most of it is down, but after the illness, you can see the TSH can go up during the recovery phase. But instead of always thinking that this is a non-thyroid illness, remember, could you treat this patient? Many years ago, when I was working in the endocrine department in the Christian Medical College, Vellore, CMC Vellore, we saw a patient in the neurosurgery department who could not be weaned off the ventilator. And the patient was quite sick. It was a neurosciences ICU, which means both neurosurgery and neurology patients were admitted, and this patient could not be weaned off. And we found that the patient had a slightly raised TSH. In my memory, it was around 16. And as like this patient, the patient had a small goiter, the anti-TP was positive. And when we gave thyroxine to this patient could be weaned off from the ventilator relatively quickly, and there was a dramatic improvement. So always, instead of saying that, okay, this is a sick thyroid syndrome, because anything can happen, it's good to always see that, would it be something else? That's the clinical reason why I suggested this case. So when to detect primary hypothyroidism in a sick thyroid setting, if the TSH is more than 25 in an ICU patient, think of primary hypothyroidism. It's not a sick thyroid syndrome. Dopamine and steroids can suppress TSH. So if you find a high TSH despite dopamine and steroids, think of it being really hypothyroidism. And of course, if there are goiter, anti-TPO antibodies, and if you find that the free T4 is low, then you should actually look for a true hypothyroidism. So therefore, in this person with many problems, ideally you would like to see, you'll see that the T3 is low, the T4 is low, the TSH is high, the antibodies are positive, the free T4 is low. Well, this is likely to be hypothyroidism. I would like to treat this patient. So that's why I showed this case. And just to say that this is a paper which I published many years back. I was one of the authors publishing this paper, which was done in a South Indian population of 971 subjects. And what you will find is that a good proportion of patients have, you see at the bottom, have unclassified thyroid function tests. So not all the patients you can classify as hypothyroid or hyperthyroid or subclinical hyperthyroid, subclinical hypothyroid. There may be people who don't fit into any of these patterns. I've tried to show you some of these patterns and I'll summarize it. In my cases, I showed you first how if the TSH doesn't come down, you could look for heterophile antibodies, which are seen in Graves' disease. I also showed a case where thyroiditis caused a low TSH, but concomitant oral contraceptive therapy caused a high T4. So look for that possibility. In my third case, I discussed how TSH receptor antibody changed its nature with TSH receptor antibody positive in the pregnant mother causing thyrotoxicosis and TSH receptor antibody positive but of the blocking variety in the baby causing hypothyroidism in the baby. And in my final slide, final case, I showed you that not all sick thyroid syndromes are sick thyroid syndrome. Sorry to use a difficult kind of sentence. Not all non-thyroid illness are non-thyroid illness. Some of these non-thyroid illness could also be thyroid illness, and you must still look for primary hypothyroidism, thyroid toxicosis, which may truly exist in some of these patients. These diseases are very common. Ladies and gentlemen, if there are any questions, I'll be happy to answer them. It has been a pleasure discussing these cases with you in the interpretation of thyroid function tests. I'm sure that all of you have, as clinicians, would have gone through such cases, and there may be different ways to manage these cases, and no one way may be completely correct. So I've discussed the way I approach these cases and these case vignettes, and it has been truly a pleasure discussing this topic with you. Thank you so much.